Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicines Clinical Advisor here at PrescQIPP. Hello and welcome to this episode of Talking Meds, where I'm joined by Emma Kirk, who's the Medication Safety Officer Network Lead for NHS Specialist Pharmacy Services. So she's an MSO lead for SPS. They're the abbreviations that we're going to be using today. Emma and I are going to be exploring the thorny issue about medication safety and some of the initiatives to improve this. We'll look at the role of MSOs within England and some of the commonly seen areas, such as look-alike, sound-alike areas, so LASA areas. There's another abbreviation for you guys. I've also got a bit of a cold here, so I'm not going to do much talking today. I'm going to leave that to Emma. So listeners will be delighted at the prospect of that. Emma is a nationally recognised leader in medication safety. As the MSO Network Lead, she provides strategic support to MSOs across England and drives forward the national medication safety agenda. Her work focuses on advancing safer use of medicines through education, collaboration and system-level improvement. This shapes safer practices and strengthens professional networks to promote a culture of continuous learning and patient safety across the NHS. One of the themes that's going to come out today is that this is everybody's problem or everyone's issue to try and deal with. Having a network, sharing, learning, being in touch with people, having some education is really, really important. There are no quick fixes to this. It actually requires both changes to the system and indeed to human behaviours as well to try and improve this. So, Emma, thanks very much for joining us. How are you doing today?
Great, thank you for having me.
Just in terms of your career journey so far, I always think it's useful for listeners to know what your journey has been and what's brought you to this point of your career.
So I started my career down in London. I was a resident at Guy's and St Thomas's. A really great experience for a junior pharmacist. Following a number of rotational clinical posts, I moved into paediatrics, where I spent about 10 years working at the Evelina Children's Hospital. Then, following an unexpected rapid increase in my family size, I had twins for my second pregnancy, we decided to relocate to the northwest to be closer to my family. Then shortly after joining the local district general hospital, their medication safety officer position came up, which I was successful in getting. And I think sort of the Sherlock Holmes nature of investigating when things hasn't gone as expected really appealed to me. Also, I'm a bit of a fixer, so a role that lent itself to getting involved in improvement work really suited my skill set. Then doing that role, the MSO network really supported me, supported me to do my job well. So when the network lead job came out, I thought, do you know what? This is a way that I can then go on to support MSOs and be part of the shaping the national medication safety agenda. So here I am.
Fantastic. So just in terms of MSOs then, what do they do?
So the MSO role has been around for 12 years. So it was 2014. And initially it was a role to increase reporting of medication errors so that we could learn. So if something was going wrong in one organisation, information would feed in nationally and we could send alerts and prevent it from happening elsewhere. And I think for the first few years, that is what the role did. It was about increasing reporting within your local organisation and then sharing the learning. It's grown into more of a sort of safety leadership role where we're looking at focusing on QI, improvement work. The medication safety officer role is now in the standard contract for provider organisations, so they have to have one. Majority of pharmacists, but not all. We've got a number of pharmacy technicians that are MSOs, nurses, doctors, biomedical scientists. So it's a real varied role. But as we've all been working to improve the safety culture of organisations and increase reporting, We're now trying to look to aligning with the patient safety incident response framework from NHS England, looking at improvement, knowing our data, what's happening within our organisations, and then improving so we can actually demonstrate that we're making medicine safer for our patients.
It's interesting. During your career, you come across really big figures, or I certainly have, who've made a big impact on your career. And I remember meeting David Cousins probably about 20 years ago. So David, sadly no longer with us, but was an absolute legend of the patient safety world, worked at the National Patient Safety Agency, and was largely responsible for bringing medication safety to the attention of other people, and indeed establishing the importance of a network of MSOs. So I'm sure he'd be absolutely delighted in the legacy that actually he's left here, which is being taken on by people like you, Emma, with great passion, which is great. So, how many MSOs are there now in England?
So in England, we have got about 350, 400 on the register. But, this is growing all the time because we've now got MSOs registered in ICBs. So don't statutorily need one, but we've got many MSOs registered. And also in bigger organisations, we've got multiple MSOs. We've also got medication safety teams. So we've got specialist pharmacists, specialist technicians. Many teams have admin support. This is growing, and it's really something where we want people to think that medication safety is a career option. It's not just about being a specialist cardiology pharmacist. Safety is a specialism in itself, and there's some really great things that you can do in leadership. We've got consultant posts in medication safety, so it's really growing.
Yes, absolutely. I think it's a really wonderful initiative, and obviously safety has always been one of the kind of the basic tenets of medical ethics as well. That first do no harm thing. It's really, really important. And I think as pharmacists, we do respond to that sometimes in an adverse way, but often, I remember when I worked in hospital, you were known as being the sort of the medication safety police officer almost. That sort of the passion for that safety was really,
I think
really
we've been
important.
the safety net, haven't we? That's what we often say. We're the safety net
Yes.
for prescribing, for administration, and I think that's where it's grown from.
Absolutely, absolutely. And I think we should be proud of that, actually. I think it's one of the strengths of our profession. So, just in terms of medication safety, then what are the particular challenges here?
So you alluded to it earlier, but I think one of the things that we face is the ownership of the issues, and whose responsibility is it to drive the improvements? Is it the MSO? We've got safety in our title, or is safety everyone's business? I would say the latter. All healthcare professionals have a role to play. But one of the main aims of the MSO network at the moment is to grow and support MSOs to become leaders in medication safety, to then support our wider healthcare colleagues to all be involved.
Definitely. I mean, there's definitely that analogy there with health and safety almost. It's like, oh, we've appointed a health and safety officer, therefore the problem's fixed for our organisation. And of course it isn't, because it's everyone's concern to make sure that you adhere to the health and safety advice. And likewise for medication safety, just having an MSO does not fix your problem. It starts addressing some of the issues that you have there. So in terms of where most errors occur, or where most safety incidents occur, what are the particular risk factors that you're worried about?
I think one of the main things is those transitions of care. Our patients move across the system and aren't supported by, one healthcare record that everyone has access to. The patients are constantly moving between primary, secondary, tertiary care in and out. And therefore, any of the medication safety issues that they have travel with them. And they can be, the big sticky issues like valproate in, patients of childbearing potential, which, we need a real system response to, or medication changes that may be made in one sector that are not reflected in the next because we haven't communicated that information. So I think the transitions between our sectors are particularly vulnerable for patients. And of course, that is even more vulnerable when you've got patients on multiple medicines or patients at extremes of life, the neonates with the strange formulations of medicines, or unlicensed off-label medicines, or are more frail patients at the other end on multiple medicines.
Yeah, I think those transitions of care are really worthwhile thinking about for people. I remember the analogy, I think it was David Cousins actually talked about if you have a patio put into your house and the curb doesn't quite align to the existing patio, there's a risk of tripping over the patio there. And so that transition between one patio to the next is very similar to, well, the analogy is that that's where you go when you go from hospital into primary care or into tertiary care or intermediate care, and it's that sort of having to be aware of the need to be really careful when transferring people's medicines, making sure that there's not transcribing errors, making sure that reconciliation is done in a safe, person-centered way. And and the other thing that we've talked about at PrescQIPP actually is sort of LASA errors. And I know this was something that David Cousins was quite passionate about as well. So those look-alike, sound-alike errors. I mean, is that something that's a particular concern of yours, Emma?
It is. I think that presents a big challenge, and I think the reason is, they create perfect conditions for mix-up. And even highly skilled clinicians make errors when two drugs look or sound almost identical. And that's even more of an issue in busy, high pressure environments, which our dispensaries are, our wards are. So, we've all seen that example where you can read a paragraph where it's absolute nonsense, but the beginning and the end of each word is right, and you know what you're expecting to see, and you can read the paragraph perfectly. And that's a bit like LASAs. They look similar, you're not focused, the packaging, maybe the colors the same if you're selecting, or the pattern of the letters is the same on a prescribing system, and the human selects the wrong one. So yeah, it is a big issue that we see all the time.
Yeah, I mean, in my interest and sort of academic interest has been in sort of how people or how clinicians make decisions. And one of the great things that I read a few years ago was Danny Kahneman's work about how we have two pattern processes in our brains, or two ways of making decisions. One is where we recognize the pattern and we make really quick decisions, and the other one is where we don't recognize the pattern and we have to think. And we don't like thinking as human beings. We're cognitive misers, as he calls it. And that's exactly what you've just described with the LASA area. You see a pattern. We're really good at pattern recognition as human beings, and you think you see a pattern where there isn't a pattern, and or you see a pattern, you jump to a conclusion that's potentially incorrect. And most errors occur when we get stuck in what Danny Kahneman calls system one, where we don't have that check that says, oh, hang on, am I sure here? Yes, I am. That's fine. Even just that little bit of sort of what he calls calibration or toggling between system one and system two can make a big difference. And I think that's what a lot of the medication safety initiatives have been about. It's that putting signs up in clinical areas saying stop and think. Because if you just do things in a blasé way, then that's when errors can occur. And I think LASA errors are a really good example of that.
Yeah, and I think they occur at all stages of the medicine journey. So, our ordering systems, which the staff that are ordering may not be clinically trained staff, when you're receipting in the stock, prescribing, dispensing, administering. So there's multiple points where user error can occur. And actually, lots of these processes, people will be doing them in a repetitive way, and they've done this all the time. And then that almost makes us more blasé. And I think even we've gone from, errors from poorly handwritten prescriptions or documentation. And although we're moving to electronic prescriptions, like these are still present because busy humans can still fall foul of selecting the top option in drop-down menus and things. So although we're it's helping us, they're not perfect.
No, exactly. I mean, you're picking lists on computers, haven't you? You type in MET, and what do you get? Penicillin and penicillamine, for example. Probably if we had our time again, we probably wouldn't call them two very different medicines, a similar name like that. But we are where we are with that. And we talked about that previously with Phil Howard about the people being labelled as being allergic to penicillamine, and of course they're not. They're allergic to penicillin. So those errors can happen. So in terms of the guidance out there on this, I know there's the WHO guidance on LASA errors, isn't there? There's that, and what else is there?
So, and I think the World Health Organization document is really useful because it's got recommendations for sort of the companies developing medicines and packaging, got some for healthcare professionals, also some for the patients and caregivers. So, and again, this is a lot of what we need to do. If we're going to tackle this, you have to go from every angle. And the suggestions are, you need to identify your LASA risks proactively. So when new products come into your organization, just having that risk assessment process, do they look like anything else we've already got in? Do we need to therefore segregate them on shelves? And looking really at the systems that we've got to try and intercept the error before it actually reaches the patient. And then looking at what preventative strategies we can implement, improve labeling, storage changes like standardization. So there's lots of things that, again, not one solution is going to work, but sort of layering them will. And it's something that's also covered by NHS England's general principles that should inform local safety initiatives. This is NHS England have got their enduring standards, which are specific alerts, which we should be mitigating against. But then there's also those general principles, and that's the things that we've known about, how we use risk assessments, how we use our policies to guide our safety work, knowing our data, what have we seen going wrong, and then using that to make those local safety changes, which one size doesn't fit all. The type of your organization will affect how you need to try and make these things safer.
Yeah, absolutely. So PrescQIPP did a bulletin back in May 2024 on LASA errors, and again, we'll put that in the show notes. And we've also done some e-learning back in 2025 as well. Again, we'll put those in the show notes. So things like that, if people aren't aware of the issues and want to know about what they can do about it, then that can really help.
It can, and I think it's really useful like the e-learning, there's CPPE e-learning as well, and actually giving your staff the time to think about it, to reflect, to think about strategies that will stop them from making those errors is really useful. The stuff's out there, it's just sort of us socializing it and it being part of inductions. It's really important to try and embed that for our staff.
Yeah, I think that's a really good point. Making time to allow staff to be aware of this and have some education and training on this is really, really important. It's that thing about failure demand again, where we don't do things properly in the first place, and we end up causing a load of work for us down the line, or for somebody else down the line. Whereas actually investing some time in someone to say, right, okay, spend some time understanding about what medication safety issues are, understanding stuff around LASA areas and what can happen, can actually save you some time in the long run if you spend some time investing in that.
That's one thing where the network's really useful. So we've got the national MSO network, and we've also got regional networks. The Northwest network, what we've done is we've built an induction package, which is a set of PowerPoint slides, but it goes through what medication safety is. It gives you examples of LASAs, examples of things that you need to know. And so it's there now for organizations to use to adapt for their own needs. But saying when you've got your staff who are in induction, it's a really good time to use that. You're setting the scene, aren't you? This could happen, but you're also setting the expectation that they'll be part of the solution.
Absolutely. No, that's brilliant. And SPS, the Specialist Pharmacy Service who you work for, there's lots that you guys do as well, isn't there?
There is. We've got, on our website, we've got suites of resources on preventing errors on the medicines journey. And they sort of look at understanding design for safety in medicines, packaging and labels. We look at purchasing for safety. And that's one thing where organizations should have purchasing for safety policies, and this sort of helps the users to develop those. And then we've got resources that look at managing medicines safely in pharmacies but also in clinical areas. So you can use those sort of to benchmark against, ask the question, are we doing this? Or are we safe? And then SBS also support the MSO network through the MSO monthly webinars. And we use those to share real life examples of where errors have been made. So MSOs contact us with pictures of packaging and things and say, this has happened or this nearly happened. And we then ask them to share with us the improvement work which has been undertaken to minimize recurrence. So whether they've segregated, whether they've changed the product that they brought in, they share safety alerts, and all of those then we save on our futures workspace, so people can just lift and shift. If that error's happened in one place, it can happen somewhere else. So the MSOs are really good at sharing what they've done so other people can just take it and implement in their own sector.
Yeah, it's finding those patterns, isn't it? If this has happened to one person, then it's happened to one person. But if it hasn't, and that one person has shared that, and actually you find out that this has happened with 50 people, then that's a pattern, isn't it? And therefore you can do something about it. Emma, that's been really useful. Just in terms of, just to end this conversation, what do you think the 3 things clinicians can maybe do differently here around medication safety?
I think when we're talking about LASAs, on an individual basis, remember that nothing beats reading the label properly. But we all need to be aware of those situations which make us more vulnerable to errors, being busy, helping out colleagues, working in unfamiliar environments, and really sort of taking the time to not be complacent. But then going on to map out the processes in your system, that's a really useful way to foresight any risk. It helps us to mitigate them before they occur. I've mentioned organisational purchasing for safety policies. They can really support this. And looking to review the systems and strengthening them is the best way to support the humans in the system, and utilising technology wherever possible and standardisation where we can. And finally, I think if you catch yourself about to make an error, think about what led you to detect it. Those good catches are really useful because they help us implement safety systems. Consider, what was going well that day. And these are the conditions that we really need to replicate. So those near misses or good catches, actually focusing our work on those is a really useful way to make safety improvements.
No, I really like that. That's really 3 useful, practical, pragmatic things that people can do as a result of this. I really like the idea of that sort of calibration of your effective state, if you like. What state are you? Are you relying on system 1 here, or are you hungry, angry, late, or tired, or maybe all 4 of those things? Because funnily enough, those halt situations are when, again, errors can happen. Those slips can happen. The processes are really important, and the combination of the processes and the human elements of this are really important. And those good catches, I really like that. I don't like near misses, and I'm glad we're not using those words anymore as often. But those good catches. So what was I doing here, and what led to that situation? Having those time. That time for that reflection with either by yourself or ideally with someone else where you can talk it through. I remember the first dispensing error I ever made, and I sat down with my dispensing manager afterwards and we talked about it, and that was actually 30 years ago. And that it's a really, really important thing for people to have that sort of that time out to be able to think about what's going well, perhaps, but also perhaps what led to that good catch as well. So Emma, that's been absolutely fascinating, really, really interesting conversation. We'll put links in the show notes to the resources that we talked about. And thanks very much. We'll see you again soon, guys. Thank you.
Thanks for having me.
Entries for the annual PrescQIPP Award 2026 are now open. The deadline to submit your entries is the 15th of May. This is open to all teams working within the NHS across all sectors. It's a real opportunity for you to share all the good work that you've done over the past year and being a chance to win a prestigious PrescQIPP Award. Check the link in the show notes and get your submissions in now.